Good afternoon. Today my topic is difficulties in diagnosis of acute febrile illness of viral etiology. Definition: acute febrile illness is characterized by malaise and myalgia and a raised temperature greater than 38 degrees centigrade, that is non-specific manifestation of infectious diseases in the tropics. Common cases of acute febrile illness in the tropical countries have similar symptoms which often mimic those of dengue. Accurate clinical diagnosis can be difficult without laboratory confirmation, and disease burden is generally underreported. Population-based laboratory confirmed incidence data on dengue and other causes of acute fever is needed, as there is a rise in acute febrile cases of viral etiology. Many cases of acute febrile illness are increased in India. The rise in prevalence is based on the data of WHO, ICMR, National Vector-Borne Disease Control Program statistics, and need for evaluation of accuracy of detecting viral fever is essential at local level. High mortality, morbidity, and high incidence rates during the outbreaks and resources limited settings, especially low income countries like India, led to these prospective studies. Aims and objectives of the study: aim to identify the viral etiological agent responsible for the acute febrile illness in tertiary care center, that is Gandhi Hospital, Hyderabad. Objectives: to determine the etiology of viral acute febrile illness by serological method, to elucidate clinical epidemiological profile of acute febrile illness caused by either dengue, chikungunya virus, or JE or EBV, that is Epstein-Barr virus and Japanese encephalitis, or all. A hospital-based descriptive observational study, including the inclusion criteria as patients with fever more than 38 degrees centigrade and duration of less than 14 days, with clinical and lab investigation indicating fever of viral etiology. Exclusion criteria includes that patients with fever for more than 14 days and patients with confirmed positive for viral, malarial, and blood culture. Sample size was 150 samples of acute febrile illness cases, and study duration from January 1st, 2019 to 31st December of the same year. Materials and methods: serum samples for detecting IgM antibody and NS1 antigen for dengue virus by ELISA, serum samples for detecting IgM antibodies against chikungunya virus by ELISA method, IgM antibody by ELISA from serum samples for Japanese encephalitis, and Epstein-Barr virus VC IgM antibody detection by ELISA. Other relevant supporting investigations. Results: in 150 blood and urine samples were collected from the patients admitted with acute febrile illness of acute febrile illness in the Gandhi Hospital, Hyderabad, and processed for routine biochemical, pathological, microbiological investigations. In the virology lab, serum is separated and subjected to NS1 and IgM ELISA for dengue, and IgM ELISA for three viruses, that is chikungunya viruses, Japanese encephalitis, and EBV, Epstein-Barr viruses. These are the instruments used in my study. The washer, reader, incubator, holder, and reagents supplied by the National Institute of Virology, Pune, and micropipette and stationary study material. The results: majority of the cases were dengue 44%, and followed by chikungunya virus 32, JE 4%, EBV 2%. This is the bar diagram representation of the same thing: 66, 48, 6, and 3 respectively. The case numbers for the dengue, chikungunya, Japanese encephalitis, and Epstein-Barr virus. Here, the bar diagram depicting the same in the percentages, where 18%, that is 27 cases, were undetected by the IgM method of ELISA. So, bar diagram showing mixed and co-infections. Dengue, chikungunya viruses sharing 9.33%, that is 14 cases were having the co-infections, and dengue JE co-infection was with one case, that is 0.66%, where dengue, EBV, or chikungunya JE, or chikungunya EBV, or JE EBV were not noted at all. And age-wise distribution of acute febrile illness, where 21 years to 40 years group aged candidates were infected more, around 74% were infected. Gender-wise distribution of acute febrile illness: males were 54% and 46% were the female. Among the clinical symptoms, headache is the major second most important finding found in my study, and followed by the joint pains, even in the dengue, chikungunya also, and myalgia, uh, followed by the rash. And even surprisingly, sore throat was also noted in the dengue, chikungunya, along with the Epstein-Barr virus cases. Yeah, among study population, 60% had low platelet count, 40% have lymphocytopenia, 36 has lymphocytosis, neutropenia has 56, neutrophilia has 38, increased monocytes 36% and decreased monocytes 8%, and raised ALT 93 and AST was 100% raised. PT, APTT and INR was also raised. So in the dengue and all the diseases, platelet count was decreased. In the dengue, lymphocytes were increased, neutrophils were decreased, monocytes were decreased, ALT, AST, PT, APTT, INR was also increased. Whereas in the Epstein-Barr virus, lymphocytes were decreased, neutrophils were decreased, monocytes, ALT, AST were increased. CKV and JE lymphocytes were decreased, and neutrophils were increased in the CKV, and monocytes are also increased. ALT, AST was increased in the CKV, that is chikungunya virus. In the JE, monocytes, neutrophils monocytes were increased and the neutrophils were decreased, and other parameters, that is the PT, APT, INR were increased. My study was correlated with the other studies. Dipali Savargaonkar study et al. Study conducted in the Delhi, where 5,536 cases were tested. 27.7% were dengue positive. Pavitra and Enrao et al. From the Rourkela, Odisha, 954 cases were tested, subjects were tested, in which 293 positive, that is 25%. And further, Manoj V. Murekar et al., Uthaya Shankar et al., Chove et al., Dinakar A et al. All the findings are similar to of my study, that is dengue was the dominant and age group was majorly from 20 to 40 years of the age. So conclusion, most common identified viral etiology was dengue. Though many cases present like dengue, laboratory findings distinguishes various viral fevers. Co-infections with other viral fevers gives no satisfactory results, and some cases are underdiagnosed or undiagnosed. Accuracy of the test should be improved, working more on the rapid methods. Other clinical and lab reports help cases in accurate diagnosis of different fevers. Development of algorithms for diagnosing acute febrile illness should be maintained. Small setups including PHCs can adopt IgM ELISA for viral fevers with a simple training to healthcare workers, as ELISA detecting about 82% of acute febrile illness cases. Seasonal variation of the fever records should be maintained or implemented to access the incidence of the fevers of the virus etiology. Early detection of the viral fevers will help the fast recovery of the patient and avoid the unnecessary antibiotics, thus preventing the antibiotic resistance. Vector control, mosquito control is the most effective method for preventing the dengue and other CKV and JE also. Insecticide spraying is in response to dengue outbreaks is not highly effective because Aedes aegypti mosquitoes, which frequently breed in the inside the houses. So special care should be taken for that. Vaccination is important, plays important role in the dengue. For EBV, no vaccine is available. Personal hygiene should be maintained. Thank you. These are my references. Yes. So prevention is better than cure, and I acknowledge Dr.